predominantly shoulder region and maybe get into the antebrachium to a certain extent. So sometimes it's hard to differentiate things without spending a lot of time working through the whole process. And this is really going to be a multimodal approach at the end, showing you how to use all the different things. Now, for those of y'all that never heard me talk or seen any of my writings, I do pretty much radiographs and ultrasound and everything. I mean, if one imaging tool is effective, then I always like to complement it with the other tool. And this is just to certify that I have no conflicts of interest. I have been here quite some time. How many years have we had? 10 years? 9 years? Been doing this a while. So just as an introduction, personally, I do mostly, and so hopefully it'll reflect on this, and I think anybody that speaks should also qualify what they do. I am a surgeon that predominantly does lameness and orthopedics, and I have over the years developed a keen interest in imaging. And at certain points in my career have not had all modes of imaging, but I have from the very start utilized ultrasound and embraced it. I think ultrasound is a great tool, and quite frankly it should be an extension of your physical exam. In areas in the shoulder, conditions in the shoulder can be very problematic, and over the years we've seen a lot of different manifestations of problems in the shoulder, and to be frank, I find putting talks together now is getting a little bit laborious, but I find that when I do it, I learn an awful lot by looking back. And looking back on this particular topic, it's absolutely amazing to see the change in our technology and the improvements in how we can radiograph this region over 10 years. It's remarkable. And some of the, hopefully you'll probably see pretty clearly when we go through here, this was older radiographic technology. So we had CR, and then before that film screen, and now we're in the digital age, and there's even light years ahead on some of the different imaging technologies that we have available to us. So anyway, I'm not going to spend a whole lot of time talking about the clinical exam, but it's again extremely important. And the unfortunate thing about the shoulder is it's very difficult to get a very good impression about what's going on with palpation alone. You know, there are a few cases in here that you'll see that it's pretty easy to see what's going on and palpate things accordingly. But I think the shoulder is kind of what I call a very obvious joint or region that when it starts to manifest pain, you see fairly remarkable types of problems. And as we go through, hopefully it'll emphasize that not often do we see hyperextension type injuries manifest in this joint. Most of what I was picking up when I was doing the retrospective, pulling out cases, looking at this, it's trauma. Generally, the majority of things that we see are traumatic in nature. Either in our practice, we do a lot of eventers, hunter jumpers, dressage horses, and they've usually either run into a fence or fallen doing something, or as always, they got in fights out in the field with other horses. So then the problem becomes just exactly what's involved and how do we go about managing these things. And this is a unique case, and I'll show it a little bit later on. This, for all the world, should be a dead horse, right? I mean, it doesn't take a rocket scientist to tell that this horse has got a significant problem, and as a surgeon, I look at that and go, that's not much I'm going to do to fix that. And as it turns out, the clients were over 35 years, I found that some of the clients are smarter than we are. And I'll tell you the story as we go along, but I sent it to 5 friends of mine, other surgeons, and I had 5 different opinions about how to manage it. And then so those of y'all that are young and do that, I'm going to warn you that that's a good way to get completely confused. It's great because you get a bunch of opinions, but it just stuns you that there can be so many different ways to interpret some of these things. And suffice it to say that this horse is still alive. I submitted my proceedings in a PDF format. I'm sorry. but they wanted me to do it in a digital format with just WordPerfect. I said, just send them the PDF because I've published this before. It's got all the pictures there. It's a lot more convenient than me just giving you a text article. So spend some time looking at that if you don't mind. I saw when I went in there that they had referenced it to the website. So I think it's a pretty good, well, at the time I thought it was a good paper. Anytime you diagnose a lameness, there's any number of ways to approach them, but the clinical exam is extremely important. And again, radiograph and ultrasound. I have thermography up there. I don't use it very often in the shoulder. As a matter of fact, I wished I had one now that I could use a little bit more consistently. It's the sort of thing that I think can give you good information, but when you start getting up into the trunk, it's probably not as effective as you had hoped it would be, but when you see some of these muscle injuries, it can give you a pretty good impression of significant change in blood flow to certain areas. Now this is just kind of your typical, and then I also, most of these cases have had nuke med as well. And I like to do nuke med up into this area. We've talked about the cervical spine and things that are going on in some of these horses, and I think it's a great way to differentiate a lot of the different problems we see. Now this was, as usual, a veterinarian's horse. And they can be quite confusing. That horse actually went home and after a month became sound without really a definitive diagnosis. As opposed to something like this, where this was a young thoroughbred foal, got out, did what it normally does, got between the fence lines, ran as fast as it could through the end of the fence at the end of the lane. And obviously you can see pretty much what's going on, but this has got a pretty traumatic injury. And at the time, it was somewhat difficult to get a good radiograph. And I will tell you, before we even get into it, that ultrasound's a great tool for looking at a supraglenoid tubercle fracture. If you're out in the field, you don't have your ultrasound, you want to document what's going on, pretty easy to stick the scan head on there and see a break in the cortical margins. You'll see a hematoma that's manifesting in the fracture plane, and it's quite nice to use it in that short term. As you saw, that's about as definitive as a cranial shortening of the cranial face of the stride that you're going to get. And as I grew up, and I'm writing a new chapter in Adams, and I thought, well, I'll go back to my original Adams book and look at it. Y'all should look at the original Adams. And I'll refer to the Adams and Rooney. I don't know if many of y'all that knew a gentleman named Rooney. He was a very intelligent man, and he talked a lot about some of the things that we're going to talk about, top lines, and he's like a physicist. He could tell you exactly what was going on and the moment arms that were generated, why he thought injuries happened. But that's also another book that I would probably tell you to look at just as a matter of interest. And you know, I've been complaining at you guys up here that y'all are making too much noise.
Yeah, no.
The thing is, I'm sorry, we need to fix that.
I think we should just take it up.
Yeah, I'm sorry. I diverged, but that's the kind of person I am, especially at this age. Well, you know, it doesn't take much sometimes to figure out what's going on. The history of trauma is usually fairly self-evident. Don't want to spend too much time talking about the clinical pictures, but, you know, if you've got swelling in this region, obviously we need to spend some time elaborating exactly what's going on. Manipulation is very important, and I'll show you some specific maneuvers that you can do if you have an area of interest that you might want to elaborate in terms of creating a source of pain. But what I was starting to talk to you about Adams was, if you see a horse that's traveling on a lunge line and he's laying with a limb to the outside of the circle, what do you think Adams said it was? A shoulder, right? A shoulder, and then as we progressed through the years, then it became a high suspensory, right? And now, I think most of us that do a lot of lameness work figure that the outside of the outside limb, the medial side of the outside limb on the foot is also as big a problem as anything else. But when I see a horse that's circling and lame with that limb to the outside, I always think about the shoulder as a potential source of a problem. Now, that being said, if I had a nickel for every time somebody came in and told me that their horse was shouldered, and I blocked it out to the foot, I'd be a wealthy man, unlike what I am right now. And maybe I could have afforded to be a radiologist, but as it is right now, I'm a surgeon. And this was kind of an interesting case. It just highlights the fact that there are certainly some conditions that, boy, they manifest. I don't think it takes too many people to figure out where that horse is lame. And he was referred in he came out of the show, and this was how lame he was when he got there. They really wanted to know what was going on, so he had been doing this periodically for about a month. And I'll show you his radiographs and bone scan later on, but this is him coming out of bone scan. So we're going to scan him again and see how he's doing. What sorts of things do you think can cause that much of an improvement in lameness that quickly? Any ideas? First thing I think about is a cyst somewhere. A radial cyst will sometimes do this. And oftentimes they won't necessarily be this lame for that long a period of time. But you know, that's just one of the things that's on my mind. Now, I only put this in here, and I don't think that it's going to portray very well. It's a little dark, but hopefully this is kind of a common presentation of a horse coming out of the field. Can you see the lateral luxation of the shoulder joint? It's not as dramatic as what you would normally see, but it actually pops out, and that's evidence of suprascapular nerve injury. And things have changed a lot since I got out of vet school and was trained as a surgeon. We always wanted to do something for this, and now I've learned this is probably better. One condition is better left alone and to allow conservative management, because a lot of them will come back and do fine on their own. So, that being said, let's get into some of the imaging, and I always start off with osteology, because when you look at these areas, joints in particular, you need to know the bone contours. And this is a very unique area. This in the elbow. I would strongly suggest, if you haven't done it already, go back. One of the best references for what you see on a radiograph is Adams. Adams has got a nice line diagram, and it shows you all these different contours that could potentially be projected in your radiograph. But this is a very unique area in that on the left is the greater tubercle, cranial and caudal eminence, and then you've got the deltoid tuberosity, and then you've got the head of the humerus on the back side. And this is the front side of the humerus with its intertubercular groove, greater tubercle, intermediate tubercle, and lesser tubercle. And then you've got this is what's really kind of interesting to me. This is a phenomenally large head, and I'll show you when I put the scapula on top of it in a later slide just how much of a discrepancy there is. Normally we think of joints as being fairly congruent, right? That's part of what allows them to be stable, is the congruency of the bone contour, and then we have collateral ligaments. Well, I'll tell you right now that there are no collateral ligaments in the shoulder, and therefore there's the ability to allow this discrepancy. And then we've got the scapula. With the neck of the scapula that comes down, we've got the supraglenoid tubercle, and you know, this is an area of weakness. And then I think I have a few cases, that's an area of protuberance that sticks out, and the spine of the scapula frequently develops sequestrums. So I want to show you a couple of little tricks to think about when you're looking for sequestrums in the scapula. And this just kind of shows you the discrepancy. Very large humeral head. And then the other thing that's important to remember from a radiographic projection standpoint is the medial border of the glenoid and the lateral border of the glenoid are not at the same level, right? So when you take a radiograph across there, they're going to be separate and appearing as lines across that humeral head. So, and then there is a little concavity associated with that as well. So quite remarkable osteology. And if you can take that into consideration, it really depends on how you're coming across here. Now, the other side of this whole deal is when you're taking a radiograph, what are you trying to do? You're trying to pull the leg forward and take a medial to lateral, and we'll get into that a little bit later on. But if this horse is lame in the shoulder, it's sometimes problematic to get them comfortable enough to get that out and then catch that projection just like you want them. So we've got this biceps brachii that comes across the face of it, and that's really what's going to create the cranial support of the joint. And then you've got this dense joint capsule all the way around it. And I'll get a little bit into that, but then you also, on the caudal aspects, you have the triceps apparatus. And I think I've got this to show osteology and the joint capsule that exists around the shoulder joint, but then you have another synovial structure associated with this in the biceps bursa, but then you have all that is covered in muscle. So pretty much what you've got on the lateral side is the supraspinatus, and the interesting thing about the supraspinatus is it is on the dorsal border of the spine and scapula, right? But as it comes down, and I'll show you the muscle, it divides. So one bundle goes over medially and the other bundle goes laterally. Lateral goes to the greater tubercle, right next to the infraspinatus as it crosses the caudal eminence of the greater tubercle and goes down and attaches. And then you've got the infraspinatus in that distal border as well. And I probably will repeat myself in some of this stuff, but the infraspinatus does have a bursa as it crosses over. Doesn't often present itself as having fluid unless there's some sort of a traumatic injury or some indication that, or some reason for it to accumulate fluid, like some sort of blunt trauma. There is a small bursa sometimes associated with the supraspinatus, but I have not been able to see that to this date. This is just the biceps tendon flipped back, big fibrocartilaginous type structure as it courses over that intertubercular area. And the thing that I want you to remember, and I'll emphasize it again, as the biceps comes around, it changes and fulcrums around that intertubercular groove and then comes back. So if you follow the principles of ultrasound, beam angle at 90 degrees, the fiber pattern of the structure you're looking at it, you have to change your beam angle as you go all around all the way. And that takes a little bit more effort to get a good scan, and don't feel like it's a problem that you're having getting a good image. You just have to work the image really hard. Now hopefully throughout this whole session, we'll start getting into some indications for off-angled imaging. But this is not one of them. This is something where we really want to be at 90 degrees to the fiber pattern of the structure we're looking at. And just to bring up, in the dog, for those of y'all that might do mixed animal practice, the biceps bursa and the scapula, or the shoulder joint, communicate pretty much all the time. In the horse, it's very rare. So we treat them as separate entities. And this is just kind of showing you joint capsule, biceps bursa, and all the muscle mass around it. The triceps, the deltoideus, infraspinatus, supraspinatus, and then the brachiocephalicus would be on top of all that. So as we go through and we look at these things, and I think I showed the infraspinatus coming across right here. Now, I had the luxury, and for those of y'all that don't really recognize this, if I have an MRI of a horse's shoulder, it's probably not a good thing for the horse, right? But it's pretty unique in that you can see the anatomy fairly clearly. And there's that supraspinatus that I was telling you about. Look at there's the supraglenoid tubercle, and you're already seeing it divide into two bundles. And then there's the infraspinatus, and I'll show you another slide that emphasizes a little bit. On the medial side, it's the subscapularis that provides the support as it forms a tendon and goes across and attaches to the lesser tubercle. So, what are y'all learning already? The most important thing you learned in vet school was anatomy, right? You'll never get away from it. Anatomy is crucial to everything that we do, particularly those of us that do a lot of imaging. And I find it interesting that I get to advise vet students, and the one class they have the most problems with is anatomy. And I find it's the most intriguing portion of my job is to sometimes go back and revisit the anatomy to make sure that I understand it appropriately. But it is a very unique area up here, and as it crosses the face of the joint, its origination is from the supraglenoid tubercle. Dives around, and I'll show you on ultrasound that there is a very heterogeneous echogenicity to that structure just after the supraglenoid tubercle. As it comes down a little bit closer to the intertubercular groove, it starts to form two bundles with an isthmus between them, the lateral being bigger than the medial, the lateral being more superficial than the medial. Unfortunately, it's very difficult to get both of those in the same scan head, so sometimes we put them with a split screen and put them side by side. And then on the back side, we've got the long head of the triceps apparatus. So there is a bursa, although it behaves very similarly to a tendon sheath. It wraps around, it is interposed between the biceps tendon and the intertubercular groove, but it wraps around the medial and lateral borders of the biceps tendon. So we can get in there and move around. And I will talk a little bit about arthroscopy, because I think tenoscopy, bursoscopy, whatever you want to call it, I think it's another imaging tool, and in fact allows us the opportunity to do some work inside of these structures. And one of the other interesting things about the bicipital bursa, and I'm really diverging here, but it is seemingly one of the few synovial structures that I see, not common, but it does seem to have hematogenous septic arthritis occurring, or septic bursitis occurring into it. And what I think is really interesting is some of these bursal cell counts can be in the hundreds of thousands of cells. And these horses are not necessarily that uncomfortable. So that's another good indication to stick the scan head on there on a horse that's starting to develop some swelling on there, and there may not be necessarily an overt traumatic injury, but we frequently want to look at those areas and be very, very cognizant of the cell content. And when I say cell content, you can get a pretty good impression of how cellular the fluid is by ballottement, right? You push on it and you watch it swirl. Hematomas or hemarthroses, very uniform little specular reflections, cellular changes that have clumps of fibrin, more indicative of white cells, and fibrin starting to accumulate in that area. I only put this in here because occasionally we will do young horses that have potential septic arthritis or bursitis or injuries in this area. This intertubercular area, the intermediate tubercle, is a cartilaginous model in the younger horse, so don't consider that abnormal. And I'm only going to talk briefly about the fact that there is a report of hypoplasia of the tubercles, so that there is actually luxation. Benoit talked about that in some of the, I believe, warm bloods that he sees in France. I don't know that I've seen one in America, but this is not hypoplasia. This is just a cartilage model that hasn't turned to bone. You can see this has now got a wave of ossification that's starting to come up into that area. So what are the things we're going to look at? Biceps tendon, bursa, the humeral tubercles as they go across, the supraspinatus tendon, infraspinatus tendon, rule out bursal problems with the infraspinatus, and then we like to look at the shoulder joint. And again, knowing that all those are important, there are certainly other structures that we can evaluate in this area as well. Those that I've talked about are the ones that are most likely to be clinically affected. And I only put this in here because there is one little plica that sits in the medial aspects of the joint that may add to stability of the joint, and it's only seen from my perspective with the arthroscopy. Now, there are papers out there talking about zones. I've gotten away from looking at it from the zone standpoint because I know where I'm at just based on the shape of the structure. Now, if I see a lesion, I measure it from the supraglenoid tubercle or potentially the musculocutaneous junction of the tendon with the biceps muscle. But I don't live by zones, but I do evaluate them architecturally. And you've always got the other limb to compare to. And Everybody always asks for the years and years, how do I make an ultrasound pay when I'm just learning how to use it? Well, I always, at the racetrack, said I've got to scan both sides, and I charged for it. Well, I'm only doing myself a favor because I can always determine what normal is, and I can supplement my income by doing, and I wouldn't necessarily charge the same amount to do both sides, but I would charge another fee to scan the other side. Now, the other thing that I like to do as well is if I have an acute injury, I want to come back pretty quickly and scan it again, particularly on the lower limb with a tendon or ligament injury. I did a project at the racetrack where I was using Adequan in acute injuries of the superficial flexor tendon. And I came back in 2 weeks. I scanned them every other day for a week, and then I came back in 2 weeks. Maximal lesion size on those horses wasn't happening until 3 weeks. So if I scan it when I first see it, and I say now he's on a 60-day recheck program, I'm comparing apples to oranges. I never knew what the actual lesion size was. Okay, so I've got an initial scan, I come back in 2 or 3 weeks, scan it again, and now I'm scanning it every 60 days. Well, I'll also add on top of that, we're going to do interventional, probably treatments of some sort nowadays. If y'all haven't heard, most of us are using ultrasound to make sure we know where we're at. And a lot of times it's in tendon or ligament injuries, and we want to guide our injections to get to these structures where we need them to be. So I think there's any number of ways you can make a living with ultrasound. But not only that, you're doing it the right way. So I don't think you're just padding your pocket. You're treating this case as appropriately as possible. And I always talk about clipping. If you've got a horse in the show season, it's the middle of summer, you don't necessarily have to clip them. A lot of people will use alcohol. We used to say in the old days not to use alcohol because it would denature the rubber in the probes. That's not seemingly enough of a problem, but I would talk to whoever you bought your ultrasound system for just to make sure that that's not an issue. I do a lot of lubes and stay away from alcohol except when I'm doing interventional procedures, and then I will use alcohol. And we'll talk a little bit about that potentially as we go along. It's usually short focus. I personally like to use the highest frequency ultrasound probe I can use. And I don't feel that some of my microconvex gives me as good an image as the linears that we use. And linears are, I've got a 10, I've got a 14, and I've got an 18. And I just choose which probe is going to give me the best image of the structure that I'm looking at. So what are we going to do? We're going to start on the biceps tendon. We're going to scan the supraglenoid attachment, and we're going to follow it all the way down to where it gets to the musculocutaneous junction. As you come off of that supraglenoid tubercle, I told you it's very heterogeneous because there's fat content, and I'll show you that as we go along. Then it becomes bilobe, and you'll see it interdigitate very nicely with the intertubercular groove. And I keep emphasizing that intertubercular groove because we've been seeing a lot of things that manifest not necessarily as biceps bursitis, but a reaction to some of the, is that me? Jew?
We got her out.
Okay. So anyway, recognize that there's a very heterogeneous area that you're going to have to deal with just below the supraglenoid attachment. And the bursa is typically not. And this is just a representation that you've got to change your beam angle as you go around. And I'll spend a little bit more time. Now this is kind of an interesting in that this is coming from musculocutaneous junction proximally. So it kind of shows you how this changes. And look at the fat content as we get up. Okay, there's intertubercular groove. Here's bilobe. Now we get into this larger area, and it's very heterogeneous, and then it becomes attached to the supraglenoid tubercle. So here we are, a little bit of muscle on the top. That's normal, and when you scan some of these horses, you'll see a little layer of muscle on the top. That's not edema. That's probably a normal structure. The remnant of the biceps muscles that comes up on that cranial face of the biceps tendon. Here's supraglenoid tubercle. Here's this semicircular attachment, and then this is what it looks like. That's transverse view. This is longitudinal view. And there is the occasional enthesis change that we'll see at that location. This is just below that. You can see it's very heterogeneous, and sometimes we can't get a really good look at the caudal border of the biceps tendon. Here's brachiocephalicus on top of it. Here we are coming down, and this is going to be the medial lobe. The medial lobe, if you look, is going to be deeper than the lateral lobe. There's an intertubercular groove. We need to spend more time looking at that border. Thankfully, there's that little muscle that I was telling you about that's not abnormal. And this is the greater tubercle coming up right here. And that's thankfully where we see a lot of the fluid accumulation and bursal hypertrophy is right at that junction between the greater tubercle and the lateral lobe. And that's where I'm going to ultrasound guide my sticks most of the time. And I don't know that we talk too much about it, but there's a couple of ways to do ultrasound guided sticks. Kurt showed you the most comfortable way to do it, where the needle crosses or is right in line with the beam or the beam that comes out. You can do a transverse view where you see the needle cross the beam. Now the unfortunate thing is you don't always know where it ends up, but you can scan back and forth to see that little hyper-intense, hyperechoic area. And I will frequently sometimes do a transverse view here just to get an idea where I want to stick my needle, and then I'll rock it up in longitudinal and watch it go down into that fluid pocket. So the lateral lobes, obviously, right juxtaposed to the cranial eminence, the great tubercle, and then obviously they go around the intermediate tubercle to join. And this is what we try to do. We try to join the split screen so that we can see the whole structure together. Now, the one thing that I would tell you is I would strongly suggest you look at the contour of the bone at this level, because we see some changes that will develop in there with chronic change in that area. So the supraspinatus, I've already shown you it's two muscles. It's going to form two little bundles. That's what it ends up looking like right at that greater tubercle. It's a little triangular shaped bundle. Here's the lateral lobe, and this is that area that will fill with fluid and synovial material. Now, if you start up high on the lateral bundle, this is starting in the middle of the muscle on that. Remember how I showed you it had two bundles? This is the lateral bundle, and that's what you pick up right there is that little fibrous, that little fibrous area in the middle. And watch it as it goes down. Muscle condensing down into tendon, and then the tendon attaches to the greater tubercle. Now, I don't see that necessarily as a primary problem in a lot of cases, but I've got a couple of cases in here to suggest that it was traumatized and is a problem. Now, the medial lobe and the medial bundle, as it attaches, is a little bit more difficult to get to follow it all the way down, but I think you can probably do it on occasion. And again, it goes to the lesser tubercle, and it's coming down and it's going to attach right here. Now, it's off angle, but it has the same sort of tendinous bundle in the middle of the muscle, and then it attaches right there. And sometimes you'll see bone changes at that site. Now, those of us that grew up without necessarily using ultrasound in this area and we blocked a bunch of shoulders, our window to the shoulder joint is the depression between the cranial eminence and the caudal eminence is that little dip, and then the infraspinatus comes across, and you use the infraspinatus as your guide to get the needle in there. And if I get to it, we'll talk about how to inject that area blindly, which is oftentimes what was used in the past. And you drive the needle in pretty much parallel with the ground, 45 degrees off of lateral to medial. And I usually stuck my finger in about thumb's breadth above that depression, and then drove it on the back side of the infraspinatus. And then you drive it until you hit cartilage. Now, the infraspinatus is kind of it's unique in that it comes across. There's caudal eminence, and it's going to come down here and attach to the humerus as well. And we won't spend too much time other than to look at it, because it is rectangular in shape in the muscle bundle, like we saw with the supraspinatus, and it comes down and it forms a trilobed appearing tendon as it crosses the the greater tubercle. And hopefully you can see that. Here we are up in the muscle, and it's kind of rectangular. Now it's coming down and forming a trilobed bundle as it crosses the humerus. And that's right where your bursa is, sitting underneath there. All right? So bone contour is very important, particularly here. That's the most lateral structure we have. And if you've got damage or trauma, you'll see irregularity under there and fluid accumulation. And I've got some... Now the shoulder joint, again, most of the shoulders that I do, I like to look at them in longitudinal because it gives me a better impression of what's going on from the joint. And I have a mentality to look at things in a sagittal plane or a frontal plane before transverse, except with when I'm looking at tendon and ligament. So that's typically what I'm going to do is I'm just going to stick the scan head in there. This is the glenoid, this is the humeral head. And you can see things fairly nicely, and fortunately or not, a lot of the OCD lesions we see are on the caudal head of the humerus. So that's not the whole picture, and I'll show you some examples of that. We see just as many lesions in the glenoid as we do on the humeral head, and you can't really tell much with an ultrasound about that area. So what sorts of things do we use ultrasound to look for? Any kind of a puncture wound, particularly to the point of the shoulder. Stick the scanner on there and find out where it went. And the other thing that I'm going to teach you, or hopefully present to you, is don't just be limited to sticking the scan head on there. Sterile prep the wound and stick a foreign, I use a teat cannula or something in there to find out just where it went. Don't be aggressive, but you want to get a pretty good impression as to what's going on, and I'll talk a little bit about using some contrast medium periodically. If you're just trying to figure out with ultrasound what's going on, you don't have to use contrast material. You can even use just fluid and see if you can blow things up. And I think that's even true when you look at some of the other synovial structures in the joint. We do a lot of digital flexor tendon sheath blocks, right? And then we never look at them again. Well, you've just created a perfect environment to look at what's going on in the superficial flexor and deep flexor tendon in the sheath. You filled them with fluid. Don't forget to go back and scan them when you get done, because a lot of what we see in the sheath are peripheral tears, and the peripheral tears are these fronds of tissue floating out in the fluid. So use that to your advantage. This is just a horrible little episode that happened where several horses got shot, but it was pretty easy to see what was going on, and my residents who were hunters were trying to predict on the ultrasound what caliber bullet it was. But anyway, I like it to also document that I've got the needle where it needs to be, and you can see it as you inject. So just some examples. Supraglenoid fractures, this is what they look like. I talked about a little bit. There's the break in your contour. Actually, most of them are a little bit more remarkable in terms of the displacement, but you can see that it's a fairly hypoechoic area, heterogeneous area over the top of the fragment that's consistent with hematoma. This is another supraglenoid fracture. You can see that there's a break in the contour, and here's the other portion over here. So pretty easy to document very quickly that we've got a fracture of that scapular area, right? More often than not, that's going to be a supraglenoid fracture. Now, I'm a surgeon. I always want to know what's going on. Every time I make an approach on one of these things, I've got a pretty good idea I'm going to get a hematoma. But it's nice to know that I can look at the incision or my suture line to make sure that it's still intact. You can look at this biceps tendon, and I would happily discuss with surgeons in here how we repair these things, but oftentimes I have to cut the biceps tendon to get them back together. And then you just follow them along and see how they repair. I've had several of these that have gone back to performance even after cutting them. And then there's others that, once we go ahead and get them fixed. But I don't know that that's universally accepted. And this one, actually, one of the screws started to back out. So I was a little bit worried that maybe that was potentially infected. Well, you can look right down there and see what the soft tissue looks like over that. Now, a lot of these horses will go ahead with a chronic supraglenoid fracture You can see that it's repaired, albeit in an abnormal position, but they will have a coexistent calcification of the biceps tendon as well. So it's just nice to know all the things that are going on. I mean, you can certainly see on a bone scan that that's the area of concern. And as things usually go, we had a rash of horses that presented for, this was over, I think, a 2-year period of time, that had osteocystic lesions that developed in the intermediate tubercle on the concave area. And most of those did very well, and I'll show you one that we had to do a little bit more of an aggressive treatment. But these are usually situations where you pick them up on bone scan. But if you're aware that they occur, then there they are, intermediate tubercle, and I think you can see it right there. I've got some better ones. There it is right there. And we published 5 cases, and I think we see 1 a year or so. So it occurs often enough. They usually seem to respond to intrathecal injection of steroids at rest. The occasional one that gets really big, we've had to go in and inject, but this is just kind of like what you would see, a break in the contour. And it depends on where the cyst opens into that area. But this is actually one that occurred on the intermediate tubercle, and that's what it looks like. But this is the one that we had to go in and inject. And it's just like treatments for medial condyles. We have a tendency to want to get into these and just inject the synovial lining with some steroids. And this horse went back, and that's actually, the biceps tendon is pretty stiff, so we actually used a cannula to kind of move the biceps out of the way and then drove the needle through the middle of the cannula to get down into the cyst. When I first came to NC State, we saw a lot of bicipital tendonitis cases, and I'm not sure that I have seen them on a consistent basis since then, but these are the sorts of things that you're going to be looking for, as you would in any tendon injury. Enlargement, paraligamentous swelling around it. In this instance, bursal fluid accumulation. And I'll show you on an MRI that there are bone edema responses associated with that as well that can probably be related to some of the chronic pain that we see with them. And as well, when you bone scan some of these horses, you'll see some reaction in that area. So there's certainly fluid accumulation, and it may be that some of the bone response is in relation to the pressure from the fluid that's generated. And again, here's a case with the muscle bundle there and fluid starting to accumulate on that border. And then here's a more exaggerated case of a tendon injury. It's almost got a split in it with a lot of material in there, and then just a very heterogeneous appearance. And most of the ones that we've seen have been lateral lobes, and as you can see here, there's very heterogeneous character here, as well as fluid. Now, I'll show you some other cases that were actually septic that developed a bone response down at that same location. This is a young horse that came in out of the field. Lame, shortened cranial phase of the stride, bone scanning, and he's got quite a bit of change. Even though this looks very consistent with what I told you earlier, the heterogeneous appearance, it's right at the enthesis. And you can see that there's some change in the fiber pattern as it comes and attaches to the supralinoid tubercle. So in that instance, bone scan down the bottom told us right where it was. So that was a enthesis change associated with the and this was the one case that we've had the opportunity to do an MRI. This is the humerus. Here we come up. This is the musculocutaneous junction. Now we get into the biceps. There's our lesion. Now what's neat is it'll flow through again. There's coming up to the supraglenoid tubercle and then this attachment. Now, as we go back, just one more time, look at the bone response underneath. And I think I have a still after this as well. So see, this is a fat sat PD, and there's a bone reaction underneath that lateral lobe. So there's certainly, obviously, probably some bone pain that goes along with it. And that's just showing you what we were talking about earlier, more fluid in the bursa as well as bone edema in that shaft of the femur underneath the greater tubercle. This is what it looked like on ultrasound. So these opportunities are great. That's what that MRI of the lateral lobe looked like, and that's what it looks like on growth. So kind of a nice representation of a tendon injury in a horse that gives us all those modes to look at. So again, look at the sagittal view, and I don't know that you can see the bone edema near as well in this as you can in the transverse view, but certainly a lot of fluid around there. And I only use that as a reference for what things could look like. Now this was a horse that came in just recently, came in with a puncture wound into the bursa. This is the lateral lobe. There's already a regularity to this. I don't remember how long it had been there. I think 3 weeks before it presented. So we've got a lot of fluid and hypertrophic synovial membrane in this bursa. And this was one instance where that is the lateral lobe, and this is going to end up being the supraspinatus tendon bundle. So watch that as it comes down right to the supraglenoid tubercle. So a lot of bone reaction. I'll show you this later on. This was one of those cases where when we did a recheck exam, this is already starting to show some change, and I'll have comparative radiographs. And these are just old film showing, a lot of depth to get down to the lateral lobe, a lot of swelling associated with it. This is one of those 200,000 white cells in this sheath, a bursa that did fine. And that's the other thing, they seemingly do well with aggressive management. And so, infraspinatus, tendinitis, and bursitis. Obviously, we always look for any kind of trauma to the tubercle because it is right there at the point of the shoulder, and if it's hit from the side, it can obviously break off, but it can also, if it's farther back, create tendon injury as well as bursitis that may not necessarily be infected, although I think I have a slide in here that talked about Mary Beth's paper where she had 4 cases, and I think 2 were septic, so they're not always septic. And this is what it kind of looks like where that trilobe tendon crosses over. There's a lot of reaction, and this is down at the attachment onto the bone. So the bursa is actually up in here, and I think I have a better representation of it. There's Mary Beth's paper. She had 3 horses, one of which was septic, but quite a bit of reaction at that location underneath the infraspinatus tendon. And this was interesting. If you do this maneuver, it does stress the infraspinatus. And obviously it can stress a number of things in the shoulder region, but this is one area that might be interesting to find out. Can we make this horse more uncomfortable by putting pressure on that infraspinatus tendon? And then this is an infraspinatus that has a lot of bursal fluid and irregular bone underneath it as it crosses over that caudal eminence. And then it gets down to the attachment, and there's a lot of irregularity there. Trilobed, bursal fluid, irregular bone, and there's this attachment. So not septic. And then this one was. So large fluid pocket sticking out there. And again, we drove an ultrasound guided needle into the fluid pocket, and you can block these as well to confirm that in fact is the source of pain. And just a little talk about deltoid tuberosities. There are quite a bit of variability in how a deltoid tuberosity looks. I would strongly suggest you look at the other side as well. But this one is quite irregular, and confirmed on bone scan that there is certainly a lot of reaction associated with the deltoid attachment. And this is just kind of an interesting shoulder in that it makes sense if you think about it. This is a young foal. It's got a physis right here, humeral head and physis. And as you push on the probe, look where the fluid accumulates in the shoulder joint underneath. So we know this horse has some intra-articular pathology of some sort. It doesn't appear to be the humeral head, so we need to be a little bit more careful to evaluate the glenoid cavity with radiographs. And this was that same horse, and this is why sometimes it's a little bit aggravating. And I've kind of turned this radiograph up so that you can see glenoid, humeral head, and how it would represent with an ultrasound. And this is the horse when we finally stuck the scope in there. This is the glenoid cavity, and he's got a large cyst that once you pop into there, you'll see that there's a lot of fluid come out. And what ends up happening, the majority of the times that we stick a scope in the horse, in the shoulder, it's for OCD. And I'm becoming more and more disillusioned with shoulder OCDs in that they're usually more extensive than what the radiographs or the ultrasounds would portray. And once you take a lot of the humeral head out, these horses don't do very well. So it would be ideal if that was just a focal cystic lesion, but it ended up being a very large amount of cartilage that was shucked off of there. Now, I'm not going to spend much time about the shoulder, the radiographs themselves, but I think you can get them with handheld units. You got to be a little bit careful about minimizing motion. You know, it's always kind of a check and balance. You know, you want them sedated, but you don't want them sedated so much that they're swaying. And you would like to position them at least to the point where you can shoot across lateral to medial, medial to lateral, and try to get focused on that shoulder as much as possible. But we do a lot of obliques as well, and hopefully I've got some examples of that to show you that as we go along present quite nicely. Now, I mean, that's a handheld unit. That's a pretty good shoulder radiograph. And if I look back at what we took 10 years ago, it would have taken us probably 20 tries to get that kind of a technique. And then we do the obliques, and that really kind of isolates both the deltoid tuberosity and the greater tubercle out quite nicely, and also gives you a little bit different impression of the scapulohumeral joint. And with digital improving as on an annual basis, I think most of us are going to get to the point where we can take a standing radiograph. Now, it used to be when we were trying to evaluate OCDs, we would drop them down and stick contrast in the joint. Well, we just go ahead and take the surgery now. If we're that uncomfortable, the horse blocks to the shoulder joint, and we can't see anything on the radiograph, I'm going to anesthetize him. I'm going to stick a scope in there and be done with it. So, but that being said, if you're in the field and you're not getting a good radiograph and you really want to know what's going on in the shoulder, you can drop them and try to get a good picture. And, you know, I think a lot of us would probably argue, do I really want to have the shoulder superimposed over the trachea? There have been multiple instances where I've gotten away from the trachea and gotten a better image. So it just depends on how it represents, how that's being represented on the radiograph. I like when they're down and try to get them superimposed right over the trachea so I get a good look at the entire articular surface. Special views, I do have some, and I'm going to run out of time, but we do skylines on occasion, and we also do some contrast studies, both bursts as well. And I have some kind of unique cases where there was puncture wounds that went in. I stuck a teat cannula in there and blew them up, and lo and behold, I got a beautiful biceps contrast. Now, just because you have digital radiography does not mean that you don't need to maintain good technique. What's going on here? My resident came running to me and says, this horse does not have an olecranon. They're burning it out, right? So,
North Carolina.
yeah, North Carolina.
It's possible.
Yeah, hypoplastic olecranons. Okay, and don't forget stress. Pick this leg up and move it out a little bit, and this is subluxing. You can see right there where we're pulling it forward, it's opening up, and then when we pull it out laterally and take an oblique, that it's actually coming out of the joint there. And this just was an old picture that I really like. Can anybody see what the pathology is in that? got a fracture, right? He's also got a cyst right there. He's got a subcondylar bone cyst that allowed a fracture to propagate out of there. I would love to get that taken with a digital radiograph. Now this is how we used to do things, and you know, I do spend a lot of time prepping them, and I like to use not always an 18 gauge needle, sometimes a 20 gauge needle, 3.5 inch spinal, and I'm going to try to drive it in a little bit off of lateral to medial, 45 degrees off of lateral to medial, and I'm going to try to use 25 or 30 cc's. And you know, I can't tell you the number of times I said to myself, it's in the joint, it went easy. That doesn't cut it anymore. I think you need to know that you're in the joint. If you don't get fluid back, I think you need to, at least after you've driven the needle in there, then you can stick the probe on there if in fact you don't want to guide your injection. But just make sure that you're in the joint, because I can guarantee you they'll flow quite nicely, not in the joint. And there was a study done by rheumatologists, by a rheumatologist. Now, rheumatologists are the ones that do a lot more joint injections than a lot of the orthopedic surgeons, where they use contrast medium in the injections as they were treating these cases with rheumatoid arthritis. All these professionals combined were hitting the joint about 45% of the time. So I don't know that we're that much better, to be honest with you. To say that it went easy is confirmation it was in the joint is not really appropriate. So in other words, if this horse did not go better, I can't tell you that in fact wasn't in the joint, or it was not a joint problem. So that being said, I just think it's worthwhile guiding your injections both into the shoulder and into the bursa. And unfortunately, the more volume you use, the more likely you are to get some retrograde flow, but in these instances, I don't think it's that important. So I tend to use 25 to 30 ml in both these structures and give them 15 to 30 minutes. And I'm about out of time. I can run through some cases. I wanted to present this. This is Schumacher. And the Schumachers are always intriguing to me in some of the ideas they come up with. They wanted to come up with a way to more appropriately inject the bicipital bursa that did not have fluid in it. So their rationale was to pick the leg up and extend it and then drive the needle through the tendon. And that's probably a pretty good way to get them in there. I guess I would just be a little bit reluctant to have an 18 gauge needle sticking through the biceps tendon and have the horse start to struggle. I would probably be concerned that I could create some problems that weren't there when I started. So in my old age, I have come to embrace, above all else, do no harm. And if I can ultrasound guide a stick and prevent trauma to a tendinous structure, I would prefer to do that. But that is an option if you're not comfortable doing an ultrasound guided injection. And that just kind of shows them how they're doing it. Interesting. And this is just kind of showing how we get in there. Now, nuke med is very important in this area. And I'm just throwing this up there. I had a bunch of clinical cases, but I do think it's important to remember young, thoroughbred, standardbred racehorses, you got to worry about shoulder stress reactions, right? So I think that's something that's big. And rule out inostosis lesions can look a lot like those, but they're intramedullary, so you've got to be a little bit concerned about that. That's something that we see a little bit more often in our sport horses. We do see deltoid tuberosity fractures and a smattering of humeral tubercle fractures, but that is a very useful tool for us to get into some of that. And obviously stress fractures such as that one, and that's not a stress fracture, that's actually another one of those enthesis changes in the neck of the scap or the supraglenoid tubercle. And then just the variety of different things that we can see with the bone skin. Any questions? God, I didn't even get to talk about surgery.
I have one.
Yeah.
So over the years, I've had a number of horses that had a club foot that started to shorten up, cranial face, stride, walk, trot, and would drop to the biceps.
To the biceps. It's interesting you say that because a lot of babies with OCDs, one of the first things you see is the foot starts to come up. And I think it's just a lack of...
Repeat, I'm sure no one.
Oh, I'm sorry. He asked, he has seen a few cases where the horse started to develop a contracted foot, elevation
Well,
of the heel.
they were club-footed horses that over time developed even more of a shortening of their stride and would block to the bicipital area. And you inject the biceps bursa and flood it, and they...
Ultrasound-wise, they were normal,
Yeah.
no fluid, but they effectively were treated by
Yeah,
injecting.
probably the first ones anyway. That was still with black and white. I never could figure out why, but they
And you've had multiple cases?
probably a dozen.
Anybody else have that experience? I'll remember
I
that.
just thought it
Anybody else?
had a reason for it.
Come on, man. Look at these.
Okay, one other question. What was actually wrong with that gray horse?
Oh, yeah.
He had I can probably cut to the chase. He had a subchondral bone cyst of the glenoid cavity. I don't know how long it'll take me to get there.
And he'd be on and off lane like that.
Yeah, and I've had radial cysts do the same thing. And I was going to talk about radial cysts because we've kind of come full circle. I tend to either do them steroid injections extra-articulately because you can't get there with a scope. So we'll fluoroscopically guide a needle into there. And there's just a recent report out now where they're using screws across there. And there's actually a paper in the 90s that said if you leave them alone, they're going to do fine. So, you know, you can treat them conservatively for a while if they're not improving. But the radial cysts have, some of them have been painful after, say they went to a clinic. And at the end of the clinic, they become lame. And they manifest lameness for about 12 hours and then they're better. You know, so you're thinking, well, maybe this is a high suspensory, but they don't block out that way. And actually, by the time we get to see them, they're sound again. So we don't have the opportunity to block them a lot of times. Let me see if I can get to it. There's a greater tubercle trauma. Well, I don't want to hold up the next speaker. But there was a lot of stuff in there. Any other questions?